Hi, this is Dr. Tom Rogers at Performance Medicine, coming to you with a weekly podcast. I've been waiting for this one for a long time because I want to introduce you to a couple guys that practice cardiology and a new type of cardiology practice. It, for me, is very exciting. Dr. Dan O'Rourke and Nolan Hensley, physician's assistant. And they've opened up a practice. I think they've been going for about 3 months now. And they are doing something similar to me. They're doing a cash-based practice. And I've been doing that for 17 years now. And a few things that I know have happened to me is, number one, I had to become a better doctor when I didn't take insurance. Number two, I got better patients. And what I mean by better patients that really cared about their health. They really wanted my help. And three, I enjoyed my practice more. You know, I'm almost 68 years old. I won't retire because I love what I do. You know, experience helps a lot in this business. And if you know all this stuff at this age, why would you retire and not help people? Because we're in this business to help people. But so it's really exciting to talk to you guys today about your practice because, and by the way, there's also an endocrinologist and a rheumatologist that have gone cash only within the last several months. And they're killing it as well. You've already seen a lot of our patients, and the great thing about your practice is not only is it very affordable, and you're cutting out all the what I call BS that you have to deal with in a regular medical practice. I'm sure you got frustrated with it, as I did. There's no way at my age I would be practicing medicine if I had to do it the old way. There's just too much hassle. The patient turns out to be secondary. And the main thing for us is treating patients and getting them better. So in these days, you don't have a lot of what I call visibility in medicine. And you don't have a lot of accountability either. So a lot of times when you do insurance-based medicine, you have a lot of middlemen that are soaking up a lot of the profits. And you're having to do all these things like coding, and you're really working for the insurance companies. You're not really working for the patients. So when you have a cash-only practice, all you care about is getting that patient better. So you all have already taken on a lot of our patients. You'll get them in the next day or that day a lot of times. And that's one of the major things about your practice because, you know, people are worried about their heart. That's a serious thing. They can't wait 2 months for an appointment. You know, by that time they're either dead or, you know, it's gotten better. They don't need to see you maybe. And I'll talk a little bit about later in the show about what they should worry about and what they shouldn't worry about. So I want you to give us a few pointers on that. But Dr. O'Rourke, let's start with you first. Tell me how long you've been practicing cardiology.
I've been in clinical practice since the late 1980s. Been in this region more or less since 2005. And it was just recently that we left what we called the corporate model to do this practice. We just felt a real burden for outpatient medicine. At this stage of my career, I have an affinity for outpatient medicine, but we just realized this is where it starts. I mean, most cardiac care does start in the office. Of course, there are a handful of patients that present to the ER with emergencies, but most symptoms are adjudicated by us first. Right. And we just felt a burden for patients because many of these folks have high out-of-pocket expenses with their insurance. And then Nolan and I learned the last few months, like you mentioned a few moments ago, it's access. We didn't emphasize that as much in our early thinking, but it is a real problem. It could take 6, 8, 12 weeks to get in to see a specialist and even cardiologist. So those were a lot of the motivators for us to do this, and everything you just said about quality of practice, enjoyment of practice, we've already experienced that.
Yeah, I think enjoying your practice because it's all about the patient. You know, I can't stand it when a doctor gets so arrogant that they won't listen to their patient. I see that all the time in my practice, and I'll give you a good example in a minute about a patient I encountered last week because I love telling patient stories because people need to hear this stuff. I mean, the doctors can get so arrogant at times that I've had patients come to me and for example, they didn't want to take a particular medicine or whatever. They didn't want to get a flu shot or whatever, and the doctor actually said to them, "I'm the doctor. I tell you what to do." Yeah. I mean, how arrogant can you get? Right. You know, you need to learn to listen to your patients and work with your patients because that's the most helpful piece of knowledge you're going to get is what they tell you. Mm-hmm. And so, in my experience, a lot of doctors, if they don't know about something, they poo-poo it.
Yeah.
Because they think they have to know everything. But as you know, medical knowledge changes by the hour almost. I mean, I don't practice anything like I did 5 years ago, much less 35 years ago when I started my practice. So if you don't keep up with things, then you're way behind the times. And by the time mainstream medicine comes around to something, I mean, it is way late. I mean, it's something like, because I do a lot of research, I have to be on top of things. I have to be better, because who would want to see me if I wasn't on top of things and did things in a better way? But there's just so many examples I could give you of being. I'll give you a great one that I encountered last week. There's two I want to give you, but there was a patient that came to me, and he was a 60-year-old healthy guy, and went to see his new family doc. And this is not to cut down any family docs because it's common, but anyway, he went in. He's a 60-year-old, thin, healthy guy, non-smoker, great blood pressure. And so the doctor listened to him and got some routine lab work and said they'd call him. So the doctor's secretary did call him, and it was the secretary, it wasn't the doctor, it said, you're in danger of dying. We're going to call you in some medicine that happened to be a statin. You have to take this medicine. We'll see you in 3 months. Without really explaining why he needed it, possible side effects, the fact that he may need to take CoQ10 with it, whatever. But so he was just dumbfounded that they would say his life's in danger. So he came to me to get my opinion on it. So I said, well, you must have had a pretty high cholesterol. That's a cholesterol medicine. And he brought his labs in. His total cholesterol was 179. His HDL was great. His LDL may have been slightly elevated. But, I mean, if it was me, I wouldn't have put him on a statin. Not that statins are bad. They're very useful for a lot of conditions. But I guess they must have plugged him into a formula and said, well, your 10-year risk is so-and-so. Right. Take this without any explanation or side effects or anything. What would you have done? Can you believe that? I mean...
Well, we see that quite commonly, and there has been a paradigm shift in cardiology. It's slow, and it's still quite controversial. I was sort of an early adopter, but I believe that the cause of atherosclerosis is inflammatory processes. I don't think a particular cholesterol number necessarily contributes to that very much. A recent study on people with familial hypercholesterolemia, they did a calcium score study. We were all taught in med school, these are people with 400 or 500 cholesterols. We were taught, they're very, very high risk. About 60% of those people had a score of 0. So they had really no calcific atherosclerosis, and we know from a multitude of studies that their long-term risk is still quite low at that point. So, yeah, with those numbers there for a primary prevention, we would not have recommended a statin.
I agree with you in your assessment of what cholesterol is, and it's a factor, but to me, it's a minor factor.
Yeah.
I agree, it's more inflammatory nature, and a lot of insulin resistance. Another great example I have of this is a few years back, we do something called a Cleveland heart panel. It's probably the best thing I do at my practices. It's a very complete, in-depth blood test that shows me not only your cholesterol, your HDL, LDL, but the particle size, whether you have ApoB, what your measurement is, LP little a lot of things that are really detailed but very important, much more important than what your total cholesterol is, your HDL, LDL. Even has homocysteine and all the inflammatory LP plaque test, HSCRP, all the inflammatory, plus your insulin resistance numbers, which to me is more important than your cholesterol numbers. Yeah. So we're looking at all that, but the reason I bring this up is because a couple of years ago, I was going over a patient's Cleveland heart. And this is the Cleveland Clinic, probably the best place in the world for hearts. So I went over it with him, and this fella had a stent a few years ago. And I said, do you follow up with your cardiologist yearly? And he says, yeah. Matter of fact, I see him next week. And so I go, well, make sure you take this Cleveland heart panel, and they won't have to do any more blood work on you. and be taken care of, and also he said, oh, that'd be great. So I saw him back about a month after that for something different, and I said, well, what'd your cardiologist think about your heart? He went over your panel, maybe you ran a treadmill. I don't know what do you think? He says, you wouldn't believe this. He goes, I'm never going back to that cardiologist again. I go, why? He goes, well, I presented him my blood work, my Cleveland heart panel, and he looked at it and immediately threw it in the garbage can and said, this is BS. And I could not believe it. So one of my other cardiology buddies is a sharp guy. You know him. And we were talking about it, and we both came to the conclusion that the reason he did that was, number one, he didn't know how to interpret it. And maybe because it wasn't his lab. He couldn't make any money off it. I don't know. But I started laughing when I heard that. Number one, the guy just lost a great patient, and he lost the trust of me. I would never refer a guy back to him. But what do you think about that? You see anything? You think people can get a little arrogant with things like that?
Yeah, and like you said earlier, we really have to listen to the patients, because in many conditions, the story tells you what the diagnosis is. Especially for people who faint and things of that nature. But along the lines of this patient that you just illustrated, the anti-inflammatory lifestyle is very, very important. And of course, there are pharmacologic approaches, which are not wrong. Statins do have anti-inflammatory effects. They do affect plaque morphology and those things. For those people who might benefit from a pharmacologic therapy, a colchicine can be helpful, daily colchicine. But having said that, the foundation is lifestyle. Try to achieve ideal body weight, exercise. As you well know, there's many foods that are highly processed. They're pro-inflammatory. And unfortunately, in our culture, we're always looking for the quick fix. And so if there's a pill we can take, we're happy. If there's not a pill, well, but it's one of those things where the patients, they just keep coming back. But you've seen them for 20 years and they're still 50 pounds overweight. Yep. They still have insulin resistance.
And they're on a list of medications that long now, which have all these side effects. Yep. And they're no healthier. They're still obese. They're tired. They're miserable. Right. And now their pocketbook's lighter because they're on all these medications that cause side effects. So I use medications too every day. I use statins. I use blood pressure medicine. I use cholesterol, everything. I use it all. But I start with what are you putting in your mouth? Right. What's your lifestyle like? Is your body inflamed? But anyway, so we could get off course on that a lot. But I like the way you practice medicine. I like your approach to it. You listen to patients. You get into detail with some of these morphologies, like what your plaque looks like. I'm sure you do a lot of CT calciums. You do all kinds of stuff at your office. Tell me a little bit about some of the things you do at your office that, to me, is amazing to have as an outpatient. Not only can you get them in the next day or that week at the least, but you run these tests at your office, and you have a low cash price on them. Tell me a little bit about this.
Of course, the basic electrocardiogram, we run that. And a lot of our tests are common to other insurance-based practices as well, but we do echocardiography, nuclear stress testing, cardiac monitoring. As we'll talk a little later, palpitations are a common situation. Unfortunately, because of certain laws, such as certificate of need laws, more advanced testing that we'd like to do, if you do CT scanning, PET scanning, unfortunately, you have to get permission from the state to do those things. There has been some changes recently in our region, and we're seeing some headway there, but hopefully those restrictions will be repealed, because that would allow practices like ours to offer an even larger array of helpful testing with prompt access and lower costs.
So you think that maybe there's a lot of things outside the doctor's control that limit us a little bit?
Yes, sir.
And it's usually in the hands of business people, maybe, or
insurance industry, other middlemen, and then of course the state. They unfortunately interfere with the practice of medicine as well.
Yeah, and that's really unfortunate. Nolan, what do you think?
We actually had a drug rep that came by the office earlier today to see us, and we were talking a little bit about these same things, kind of taking it out of the doctor's hands and putting it somewhere else. And his scenario was that his company had a recent layoff of drug reps that were actually in the field talking to the doctors, talking to the providers, and they were actually increasing the number of reps that were actually going to the legal departments of bigger companies to lobby to them, and that was the reason for the layoff. So our discussion was, it's just every step that they're taking in this insurance model is taking away from that patient-provider relationship, that informed consent relationship that you have with your patients. This is the best medication for you, not what your insurance would pay for the most, but what's best for that patient.
That's so appropriate, and I see that all the time. As one of my good friends, Dr. Paul Gorman, orthopedic surgeon, we talk a lot about medicine, the way it's going, and he and I agree that the most important relationship in medicine is patient provider, and all the other stuff is just too much, I think. I mean, we need the ancillary things. Another great story I've got, you talk about a drug rep, which are helpful, and I have many friends that are great friends of mine that are drug reps. But one of my patients a couple weeks ago went to her family doctor, and I just asked him a question, which was a reasonable question. How do you keep up with all this stuff? Being a primary care doctor, how can you possibly keep up with all these changes in medicines, everything new? You just have to study all the time, or what, which we do, people like us do, because we have to be better. But the family doc gave a very interesting but honest answer to that question. You know what it was? I learned from the drug reps. To me, that was kind of sad, but it's very true. I mean, if you're learning all your stuff from a drug rep, they're salesmen. They're not medical people. And I love them to death. I've got many friends that are drug reps, but as a physician, you can't learn all your stuff from a drug rep. You have to do your own research, use all your experience, and go from there. But I thought that was kind of a sad commentary on how we learn our new stuff, and because by the time they know about it, it's kind of jaded anyway. And they're pushing a drug. I don't push drugs as much as I used to. I mean, we're actually trained as doctors to write scripts. This is the disease you have. Here's what fixes it. And that's not the right way to do it. I mean, here in the United States, we're the most advanced country on earth. We spend so many more billions of dollars on health care than anybody else by far, yet we're 33rd on the mortality list. And I mean, there's third world countries that are healthier than we are. I mean, you walk around your local Walmart. I mean, your average person is a sick individual walking around, mostly because of obesity and too many drugs. What do you think? Do you learn a lot of your stuff from drug reps, Nolan? Where do you learn your stuff?
I think drug representatives are a good resource for certain medications, especially if I think a patient needs a medication, but maybe I have concerns. This patient, maybe their kidney function's not the best, or they're right on the borderline of a medicine dose adjustment. Definitely, I don't feel bad calling those guys and getting their opinion. Like, give me some more information, because they have resources through their companies. They can submit it to their clinical pharmacy team, give me better information about that. But no, I think that's a tough way of going about things, is getting all their information just from those drug reps. Great people. We have most of the drug reps that come by our office. We don't talk a lot about drugs. We talk about other life.
Plus they give us samples that really help out. I love samples. So there's a great place for them. I love them too. But if you're learning all your medicine from a drug rep, that's not enough.
Well, those individuals, they are trained on all the good things about that one specific drug. They know about the most common side effects, but to them, that's the best drug on the market. Yeah. That's what they have to push. So that's where you have to be the hedge around your patient. Is this really the most helpful drug for my patient?
Right, and you're looking at all the other stuff too. I mean, you're looking at as a whole patient, not just a number. Like their cholesterol's 250. Put them on the statin. I mean, I think, what's the number one drug used? Lipitor? Is that the number one sold drug?
It had been.
I think it is.
That was Pfizer's previous number one revenue generator, was atorvastatin.
Yeah, I think
it was the first $1 billion drug, I believe.
Yeah, $6 billion.
And not that it may save lives. I mean, certainly if I had a stent or I had a bypass operation, I'd be taking a statin. But a normal, healthy person that eats right doesn't probably need a statin, in my opinion. Not especially if they have a good score and they get worked up by you guys, maybe. Let me ask you a few things that I want to ask you about what to worry about with cardiology. You know, I'm going to begin a series of discussions with specialists on worry about this, not that. So give me a good clue about what you should worry about from your heart, because heart is, I mean, it's the number one killer. I mean, we've got to have these great cardiologists because heart disease kills most of us. Don't we start getting atherosclerosis in our teens, and it's inevitable for everybody, right?
Correct.
Well, what would you worry about, and what would you kind of not freak out so much about with your heart?
I think the thing we have to be most concerned about, common things occur commonly. And so we have coronary atherosclerosis, and that can present in a variety of ways. But I think patients really do themselves a service by really looking at their situation honestly. Yes, I'm 30, 40 pounds overweight. I have risk factors. I've used tobacco. My inflammatory markers are elevated. Right there, you know that there could be risk involved, even if you've not had a problem prior. But I think patients should definitely be concerned with any new symptoms, unexplained chest discomfort, unexplained shortness of breath, especially in women who have atypical symptoms when a significant blockage occurs. Unexplained fatigue. I've had women come in and say, I make the bed. 3 weeks ago I was fine. Now I'm just exhausted doing that. Well, that would be a clue that something might need to be looked into. So those types of things are very important, again, because those are potential symptoms of progressive coronary atherosclerosis. And as I said, it's a common issue. And of course, interventions can be done to help mitigate risk. As far as what not to worry about or be less concerned would be something like palpitations, where you feel an isolated skip of your heartbeat. Not saying those things shouldn't be evaluated, but I think the primary care providers can do a physical exam. If you have a normal cardiac exam, you have a normal electrocardiogram, that's very, very reassuring. Perhaps an echocardiogram would be helpful, but in most cases, palpitations are just arising from isolated beats from the upper or lower chambers, and they really don't have any long-term significance, especially in the absence of structural heart disease.
Mm-hmm. I've sent you some patients with AFib, which seems to be occurring more often, which is a serious dysrhythmia. And I talked about devices like Apple Watches in my podcast last week about how they'll pick up AFib. So I really think these wearables are really kind of useful, in picking up AFib. But a lot of times you've got that inexpensive Holter monitor that I love, that you put that patch on people, and it kind of reassures them, hey, you're having some skip beats, but it's nothing to worry about. You said that latest example, the lady comes in with not chest pain, but shortness of breath, fatigue. How would you start the workup on that? Would you run an echo? Would you do a treadmill test on her?
Of course, the first step is a
EKG.
good history and physical. We were all taught that years ago, but that seems to be a lost art. But the history is very, very important, and then assessment of risk factors. And of course, in our mindset, we're getting broader than what we were traditionally taught. So you start there. Of course, most of those patients, if not all of them, should have an electrocardiogram. But then you make your assessment. You make a formulation of what you think their risk is, or their pretest probability of disease. What's the likelihood this patient actually has obstructive disease, and then you select the test. But yes, a lot of times a stress test is helpful. A stress test can just be a simple treadmill test, but there are patients, especially middle-aged and older, where you'd want to couple that test with an imaging procedure, either a nuclear scan or echocardiography.
Stress echo.
Yeah, okay. Stress echo. We're doing a lot of stress echo. There's a lot of patient demand for that because it's a very good test. It has its nuances as compared to nuclear stress testing, but it's much more affordable. And like you said earlier, we do have a different patient population. Patients are more interested in their health and that type of thing. So we have a lot more patients who are actually candidates for treadmill testing plus or minus some imaging.
Yeah, and I like it when a patient asks me why I'm running a test on them, because they need to know.
They need to know.
They also need to know the result of that test. Any test as a doctor you run, you better give them some feedback on what it means.
Yeah.
Don't just ignore it and say this is normal, or some red flags are raised up. But let me ask you another quick question about, what do you think about taking an 81 milligram aspirin for most people? There's controversy over it. I take one, but what do you think?
Yeah. For a lot of middle-aged people and younger who have lower risk, it's probably not necessary. One of the factors that has been touted as to not take aspirin is GI side effects, but I think that's been overestimated somewhat. Obviously, when we were young men in this business, and back in those days, a lot of people with rheumatoid arthritis were treated with very high doses of aspirin. Those are the people that get the side effects. But,
right.
81 milligrams of aspirin in most people is probably not going to cause a significant risk, but it can be helpful. But again, it has to be tailored to the individual patient. Somebody who has multitude of risk factors, insulin resistance, overweight status, high inflammatory markers, and then a whole host of pro-inflammatory conditions, sleep apnea, bad teeth and gums, all those things. You have to weigh those. So the more of those you have, the more beneficial it may be to use antiplatelet therapy.
Right. I agree. There's some controversy about it. You're always reading something, aspirin doesn't help. Aspirin's good. One reason I recommend aspirin for a lot of my patients is because it really, besides prevent heart disease or keep your red blood cells a little bit more slippery, thin, it actually reduces the incidence of colon cancer by about 40%. A lot of the studies I've read, but which is also a killer. And some people say, well, if you're taking an aspirin every day, if you fall, you may have a subdural hematoma. So if you're 90 years old and you're falling all over the place, I wouldn't use an aspirin. But in a 60-year-old who, being a 68-year-old male is a risk factor.
Yes.
It's it's probably the most main risk factor, wouldn't you say?
Getting older is a risk factor.
There's no doubt about it. So to sum it up here, number one, I'm really happy you guys are out there doing what you're doing. I mean, you're so gracious and good to patients, and that to me is the key to being a good provider, is just empathy. You really care about those patients. If you didn't, you shouldn't be in this profession. And there's some that shouldn't be in this profession. So that's the ultimate reason we're doing this. And I'm like you, I like to get to the bottom of a problem. That's why we practice functional medicine. Why do you have heart disease? Why do you have diabetes? And usually it's what you're eating, or lack of exercise, or you're not sleeping. You have sleep apnea because you're overweight. Sleep apnea causes heart disease. I send people for sleep studies every day. Silent high blood pressure is so important. Many people don't know. I wish there was a better way to measure 24, 48-hour blood pressures. Because one time when they come in the doctor's office, it may be up. Do you worry about that? Or do you have any way of sending somebody home with a blood pressure monitor?
There have been studies that have shown that readings obtained in the doctor's office are probably less reliable than those taken at home. Obviously, they looked at some ambulatory blood pressure monitoring, and just from a technological standpoint, that gives some uneven data. But, we have patients measure their pressure at home, usually different times of the day, but the most important thing is we tell them not to be fanatical about it. We have some patients, they measure their blood pressure literally 14 times a day. And if they get a high reading, it starts that process, and then they measure it again. It keeps going up, that type of thing. But, if someone's on antihypertensive medication, taking a blood pressure reading a day or two a week, first thing in the morning, that reflects yesterday's medication. And then if you take some morning meds, usually by early afternoon, those meds have fully gone through their distribution phase. And so you just take it at different times of the day. Again, maybe you're measuring your pressure 6 or 7 times a week, and keeping that. But I think outpatient readings are more reflective than coming in the office, and especially our practice. I mean, people really don't want to see a cardiovascular specialist. I mean, they really don't, and then they get anxious, and what's the provider going to say, that type of thing. And a lot of times, what we'll do too is after they sit there a while, we just take it again, and it's often way down. So that initial reading.
I agree with that assessment. My dad was an old-timey physician, and he told me, right when I was in medical school, I guess, he goes, the most important words you'll ever speak to a patient words of comfort. And I've carried that with me, so I try to relax people. Because people do get nervous. They're seeing a doctor, they don't want to be there. And, a lot of we want to make sure they're okay. But a lot of times there is a lot of psychological overlay, especially with hearts, because people are worried about killing over. What's the most common medical student question? What's the most common presentation of a heart attack? Death. Sudden cardiac death. So, obviously people are worried about it, and if can be reassured that their heart's fine, especially from guys like you, then their whole persona could change, because if you're a doctor, you're dealing with anxious people all the time, especially in today's world. I mean, it's just unbelievable the amount of anxiety and depression we see as physicians.
And again, tying it into our practice financial model, they're definitely strictly related, because, as you know, the way to combat that is time and counseling. We offer 1 hour for initial patient appointments and 30 minutes for follow-up, which is really unheard of regardless of specialty. But as you know, in that time period, we can actually delve into these things. We can explain things. And that's really key, is education about what you have, what we're going to do about it, and then provide comfort where we can.
That is such a good point. The average primary care doctor spends 7 minutes with a patient. And literally 5 of those minutes are on a computer. Right. I do paper charts. On a computer, looking for codes, trying to get, you're almost like a data entry person. You're not even a doctor. You're over here trying to put this stuff in, trying to get 30 cents out of the dollar from an insurance company. By the end of the day, you've seen 40 patients, and you think, man, I don't even know where the day went. Did I really help anybody? Did I really get to know anybody and help them? So that's been my bugaboo all along. I'm like you. I like to spend time with my patients. I bet I see half the patients I used to see, but I think I'm a lot more effective, and I refuse to deal with insurance companies and have coding and all. I just won't do it. I mean, I would rather go ride my bicycle than do that. But what do you think, Nolan?
Well, like you gave the example earlier of the patient that got called with cholesterol reports and saying his life's at risk. In my mind, the provider didn't do that patient justice. No. You give them a diagnosis and give them no explanation and just say, here's a pill, you got to take it. You haven't provided that patient with any information. Haven't given them a chance to understand why they're having these problems. Haven't talked to them about, okay, well, maybe you're a little bit overweight. What are you putting into your body? Let's look at those things first. Give it a couple of months. Recheck that again. Try all these natural things. Let the body heal itself. And I think providers nowadays that are in the insurance models, they don't have the time to spend with those patients, so they just have to make the decision. I'm going to be very blunt about these things, and if the patients don't like it, well, that's their choice.
Yeah,
you're
kind of covering your ass in a way. Pardon my language, but. A lot of doctors practice defensive medicine, and that's just what they do. I was talking to one of my other brothers who's a surgeon last week, and I came up with something that I posted, and it's true. See if you agree with me. There's 3 main concerns that doctors have. Number 1, hopefully, helping the patient. You shouldn't have got into this if you didn't have that goal in mind. So that should always be number 1, helping the patient. Number 2, making a living. I mean, you have to make a living. You spend a lot of time and money getting where you are. You have to support your family. You have to make some money. Number 3, not getting sued. Those are the 3 biggies, in my opinion, that every provider has to worry about and does worry about. So a lot of times the risk, the thing about not getting sued is that you have to practice standard of care. And who is that standard of care determined by? Like that cholesterol number. I think the pharmaceutical companies and the insurance companies have their say-so in that as well. And a lot of times they don't focus on the things that you need to be focused on, like get lean. Quit eating so much. Quit eating all this processed food and sugars. That's why you're unhealthy. And it's amazing to me that most doctors, number 1, don't know anything about nutrition. I had to go learn it all on my own. And I only did it because 2 of my kids came down with type 1 diabetes. That's why I went and did it. And that changed the whole course of my whole medical practice. But another example, I love patient-doctor examples. And this isn't the doctor's fault. I'm not cutting doctors down, but this is just the way it is. I had a patient about 3 weeks ago, 60-year-old female with a new diagnosis of ulcerative colitis, which is a serious colon problem. You know, the rest of your life usually on heavy-duty, expensive medications. And so she came to me for a second opinion. She'd had the colonoscopy, everything, and it was UC, ulcerative colitis. And she didn't want to go on methotrexate. She did not want to go on Humira, which are heavy-duty, thousands of dollars a month medications that can depress your immune system and cause problems. So I asked her a question that I already knew the answer to, but I just wanted to confirm it with her. I go, did that gastroenterologist ever ask you what you ate? No. Isn't that just terrible medicine? It's just terrible, terrible, terrible. Just like your cholesterol's high. What are you eating? They never even asked that question. So it's bad medicine.
Well, so much of medicine has become checkbox medicine. It's not about satisfying the patient and making sure that they understand. It's about satisfying whoever their insurance company is. I've checked these boxes. They're here for their annual exam. I've checked their cholesterol. Oh, it was high. We've got to get them on a statin. Or, oh, they're pre-diabetic. Oh, we have to put them on a statin now because we're going to get dinged from the insurance company. Our reimbursements are going to go down. And that's just not a good way to practice medicine. That's in no way tailored to the patient.
No, it's cookbook medicine, and it's terrible medicine in my opinion. That's why there's a few practices like we have, and hopefully a lot more doctors will step out and just be a patient advocate and kind of get a little bit out of the system and work for the patient, because that's who we're working for. That's who we're their boss, really. I mean, we're their boss. Either way you want to look at it, listen to the patient, and that's your customer in a way. So treat them like humans and try to find out what the root cause problem. But I'm so happy that you guys came on with me. Nolan, Dan, thank you so much. Your practice is amazing. It's been going on 3 months. You're already killing it. And your patients are so thankful. They even call me and thank you for sending me over there. I can't believe it, the kind of service I got, and I'm reassured. You know, I'm not going to kill over. So thank you for coming, and I'm sure your practice will grow. You'll add other services, but we're definitely on the same page with the way we practice medicine, and I hope it's a better way. I'm not bragging, but I'm just telling you the truth. There's a better way to practice medicine, and it has nothing to do with insurance companies or non-medical business people. But that's my feeling about it. Any other words of wisdom before we get out of here today?
No, we just agree with that. And, this model, and again, we're new to it as well. I've wanted to do this model for about 10 years, but as a specialist, the timing wasn't right until about now. But all the different benefits of this type of practice model, you'd mentioned a little earlier about medical legal risk. Well, if you spend 30 minutes to an hour with a patient, that really mitigates a lot of that, because you have the time to educate, and then patients get frustrated if they feel like they're being rushed, that type of thing. So we just want to encourage other providers to consider stepping out. That there is a way where you do not have to be beholden to third parties, and as we can all testify, the professional satisfaction is through the roof.
Oh, I agree 100% with you. And most doctors are employed by the hospitals now. Would you want to work for a hospital?
Well, we did, but we don't anymore.
There's no way I would. I mean, I would retire tomorrow if I had to do that. But anyway, guys, Nolan, Dan, thank you so much for coming in and sharing your experience. It's always great to get guys like you that have stepped out, and it's risky stepping out. I mean, it's not an easy move to make. When I did it 17 years ago, everybody thought I was nuts to do this. You know, what in the world? You're giving up a huge practice to go out cash only. You're not going to take insurance. You'll starve. You'll never make it. I had many doctors tell me that. And here I am 17 years later. I'm much more happy. I'm a better doctor. I won't retire. And I think I'm just a happier person because I know I'm helping people in this manner. But anyway, thank you for listening to this. And hopefully we'll have you guys on here a lot more Stay tuned. What's your website? If somebody wants to contact you, tell us what's your website?
Yeah, our group is Trinity Heart and Vascular Group, and that is our web address, www.trinityheartandvasculargroup.com, all together.
Okay, we'll put that on the bottom of this. We'll print it out for everybody. Okay, guys, thank you so much for another edition of Performance Medicine. We'll see you next week.